we've got a patient lined up here. The first thing we're going to do is set up our standoff. So the difference is we have this, our focused shockwave handpiece looks a little bit different. So we need to put some gel into here. There we go. I'm going to put the small standoff because the first indication we're going to be treating is plantar fasciopathy. Now, many of the same techniques also exist for our focus shockwave. So the first thing I'm going to do is to mark out the area that's tender. So our patient that we have here, what I'm going to do is palpate and feel some of these tender areas, because one of the concepts with shockwave is we're not just necessarily treating exactly where the pain is. I'm also going to treat up that fascial plane as well. So I might move Marco's leg just out here. Marco had a fight with a prickle bush, so mind that. So I'm going to make some marks, because one of the areas that we locate, once we start treating with shockwave, we do get this hypersensory analgesic effect, and that starts to make the area that we want to treat more difficult. So I'm going to mark out a few of these tender zones. The other area that I'll tend to treat with our focused shockwave is often through this distal tarsal tunnel through here, because we often know that when we've got some of that neurogenic inflammation, we get sensitization of a lot of these nerve endings that innervate the heel. So switching the machine on, we have a few settings. What we can change on here is we can use a standard preset. So if I go into, we have all of the indications that the shockwave device has been approved for. We've got our plantar fasciopathy. It's going to give you a rough preset, but we have the ability as clinicians to modify this. So what I'm going to do is now apply some ultrasound gel, because just like our radial device, our focus needs gel as a medium so that that shockwave can be propagated. What I'm going to do is start not directly on the area where the pain is maximal, and I'm going to work into that area. So I'm going to change the frequency to 8. The intensity we can have as a standard, or we can also look at it in terms of millijoules per millimeter squared. And I'm going to use 2000 impulses set up here. So once the device, I hit that start button, the device has sort of been armed. We've got a button on our handpiece, which I can start delivering shockwaves now. And Marco, I'm just going to start moving towards the area where the pain is. You just let me know if you're starting to sense and starting to feel that shockwave. Okay. Now, just like shockwave, with radial shockwave, we're going to adjust the intensity of the energy that we're delivering, always based on patient biofeedback. So I can adjust on the handpiece, start to turn that energy up. And we want it to be tolerable discomfort. So I don't want the patient to be an 8 out of 10 pain. I usually aim for between 6 to 7 in terms of a discomfort level. And we're going to see that same analgesic effect start to kick in. So as I'm treating that area, there might be reactive points that you have a higher level of discomfort. After about 10 to 30 seconds, you're going to see that pain start to diminish. So what might start as a 5 out of 10, after 20 seconds will start to drop down. And then I'm going to slowly shift my focus point to a different area, treating all of those zones through there. So as this is a demonstration, I'm going to move on and show you some of the other areas that I'm going to tend to treat. Often with plantar fasciopathy, I'm also going to want to treat through this distal tarsal tunnel, because when we have pathology of the plantar fascia, particularly those cases where there's an acute on chronic presentation, there's an increase in that neurogenic inflammation, these nerves often become quite sensitized. This is probably one of the big advantages of using focus shockwave, is that as Professor Smits was talking about, in patients that have that regular tendinopathy, plantar fasciopathy symptoms where they've got pain first thing in the morning, that pain improves as they get moving, they might have pain after rest. These patients often respond very well to radial shockwave. But in clinical practice, I wish they were the cohort of patients that were presenting. We often see patients that are in a more of an acute or chronic presentation. And in those cases, sometimes that mechanical irritation from radial can cause discomfort and it can impact the patient's ability to tolerate that treatment. So focused, we have a greater range of energy that we can use. We don't have that mechanical irritation, so it can make it more comfortable. Now, as I'm treating around this distal tarsal tunnel, I'm going to drop the energy level right down again. We're going to activate this, and I'm going to slowly start treating up through the insertion of the abductor hallucis muscle around that infracalcaneal nerve, and I can also treat up around the medial calcaneal nerve through here. Are you feeling any discomfort through there? Yep. So Marco was saying that he's able to feel that sensation. There's a little bit of discomfort, but it's completely tolerable. I'm just going to work through these areas. And you'll often find as you're scanning over the area, there'll be points that are a bit more reactive, and that can give you an indication that they're spots that may be generating some symptoms. Okay, so as I said, we're going to sort of scan around and find those areas where there's a bit more reactive change, and the patient's going to let you know where those areas are. And once you find some of those areas, what I'm going to do is almost start to slow down, and I'm going to wait till I get that analgesic effect and the discomfort starts to diminish in that area. At the same time, we can also adjust the intensity of our energy. So this is how I apply focused shockwave for treating the heel. In this circumstance, what I'm delivering is 2,000 impulses to that site of pathology in the plantar fascia. I'm also probably going to deliver about 1,000 impulses through this distal tarsal tunnel, and I'm using a frequency of 8 Hertz. And the energy level, as we discussed, is always going to be adjusted based on our patient biofeedback. So the first session, we might use a lower amount. And then as the condition starts to desensitize, we're going to start using higher levels of energy as the patient tolerates. Now, one of the things that I do in clinical practice is almost always combine my focus treatment with radial treatment, because we know as clinicians that the symptoms might be down here, but we often have changes in that fascial chain as well. So I want to treat some of those areas. So particularly if the patient has hypertonicity through the calf muscle or trigger points, their gait's been affected because they've been walking in pain, I want to be able to treat up through that area. So what I'm going to do now is place my focus device over here. We're going to switch on the radial device. Now, when I'm treating myofascially through the calf muscle and through muscles, I'm using a high frequency. So I'm going to use 25 Hertz. Okay. And I've also got the ability on the handpiece here to adjust the intensity of the bar pressure or that energy of the shock wave as we're progressing through the treatment. So I like to have the patient with their leg in this position. I'm just going to wipe off that gel, because what I like to use is my thigh to basically put a bit of dorsiflexion into the ankle so that the muscle group that I'm treating is under some tension. That often makes it, I think, more effective. I'm going to use some gel. I'm going to show you the technique and some of the areas that I tend to treat. So before treating, what you can do is palpate through and find some of those tender points, find some of those myofascial trigger points. Often with patients with plantar heel pain, you'll find them through this lateral gastroc and also through the flexor hallucis longus muscle, which you'll find over here. And I usually also treat on this up through the medial part where we've got our tibialis posterior and our flexor digitorum longus through there as well. They're points that I typically find in practice are quite uncomfortable in patients with heel pain. So we're going to put a little bit of ultrasound down there. The radial device is going to make a little bit more noise because it's effectively using a compressor to drive that projectile, which is generating our radial shock wave. So the technique that I tend to use is I'm going to have my knee, which allows for some dorsiflexion of the ankle so that the area I'm treating is under a bit of tension. We're going to start the device up. And what I'm going to do is effectively start ironing through the muscle. And again, with biofeedback, I'm going to find some of those tender areas. If you look closely at the muscle as well, you'll often see, if we look closely at the muscle, you'll see twitch responses as you're treating over those trigger points. You see just there some twitch responses. So as you're treating through, you're going to find some of those areas where the muscle is more responsive. We got another one through there as well. Let's work up through this. A few through there as well. So the body will sort of tell you where some of those areas are. And with this technique, what I'm effectively using is with my hand that's holding the device handle, I can apply more or less pressure depending on what sort of area I'm treating. If I'm treating up through a big muscle group, I can put firmer pressure through there. If I'm treating more superficially down around the Achilles tendon, I only need light pressure because the area that I'm treating is relatively superficial. The other area that I find is often really important to treat is through, so I'm going to just move Marco's leg up the way here so it's a bit easy to see through here. I'm going to treat up through this medial side of the leg through here. We're going to treat up through there and find a position that's comfortable for you to hold the applicator tip. So as I said, you've seen that I've used a few different ways as a clinician. Effectively try and look at the device as being an extension of your hands, particularly those clinicians that are hands-on and they treat with a lot of manual therapy. Try not to see the device as something that's foreign, but something that you effectively integrate into those techniques. So I always find that treating not just the area where the pain is makes a big difference in terms of the clinical impact. And you'll notice with patients when they've had pain for a prolonged period of time, when you watch them walking into the consult room, they often don't even realize how antalgic they've become and how affected their gait is. So as clinicians, I want to try and restore their function because walking and moving is a functional activity and they're loading that tissue.